Hello and good morning. Welcome to Covered. Covered is COVID vaccine equity research dialogues, and we're coming to you from the Leonard Davis Institute of Health Economics at the University of Pennsylvania. I'm Allison Buttenheim. I'm an associate professor of nursing and health policy at our School of Nursing, and I'm also scientific director at the Center for Health Incentives and Behavioral Economics. And I'm a senior fellow at the Leonard Davis Institute, along with Professor Harold Schmidt, who's an assistant professor in the Department of Medical Ethics and Health Policy at the Perelman School of Medicine. Today, we are joined by Dr. Susan Gould, who's both a professor of internal medicine at the School of Medicine and professor of health management at policy at the University of Michigan's School of Public Health. And we're delighted to have Susan with us. So our goal for the Covered dialogues is that we hit on three topics. We look at the federal angle for vaccine equity, what's going on in the new Biden administration, at the CDC. We then turn to a state or local case study for how vaccine equity is being debated and implemented at the local level. And then we turn to a recent research study that tells us something new about the implementation and application of equity principles and equity research to the rollout of the COVID vaccine. So Harold, I'm going to kick it to you to start. What's going on at the federal level with equitable vaccine rollout?
Really, the main thing I want to flag is that while the government provides guidance on equitable allocation, this guidance is mandatory and there is a lot of variation, but at the same time, also a really powerful way in which we can work towards equitable allocation. Some states offer vaccines to older populations alongside healthcare workers, around 30 or so. And understandably, that can be very confusing to people because, there should really be a clear answer to how we do this, right? But there's three things that we need to understand. So first, there can still be reasonable disagreement about the phasing. This is not just a math problem, but values also come in and can play a role in how sequences are set up. And then secondly, it's simply a fact that on healthcare, there is difference to states. And in many ways that makes sense because, for example, states vary in their shares of older populations. So this you then want to see reflected, or it makes sense to reflect that in how you set up an allocation framework. And the most important thing is that equity is not only determined by phases and priority populations, but also how we allocate within each phase and population. Now, this may sound abstract, but it becomes immediately clear if we fast forward to the general population, right? At some point, now we're very obsessed with thinking, well, who gets it first in terms of the priority groups? But at some point, we'll allocate vaccines to the general population. And here too, the vaccine is not equally important to all people, but it's much more important for some people than for others. And the relative disadvantage that people have is really key here. And what's important is that this is expressly recognized in the national COVID strategy that came out at the beginning of January. So under goal 6 there, states are asked to describe in their allocation plans how they have or will provide equitable access using the Social Vulnerability Index or another such index. And we'll talk a little more about how this index works today. But broadly, what it is it's a compound measure of disadvantage. The Social Vulnerability Index integrates 15 variables, things like income, education, crowding, and it then computes an overall score. And what you do with that score is that you can understand how disadvantaged on average people living in a particular geographic area are, right? So while we have a lot of variation in state plans at the moment in terms of their sequence of priority groups, and while we have to accept that, what's important is that we can still promote equity by making sure that within each phase, the hardest hit groups gets vaccines the first and that the hardest hit groups are not left behind.
Harold, can I just clarify with you, do the states have to use some kind of vulnerability measure in their plans, or are they allowed to? What does the equity plan say about that?
What the equity plan says is that the CDC will work with states to ask them to revise their allocation plans such that they describe how they achieve equity using the SVI or another index.
And is that a change from what the plans that the jurisdictions, which are mostly states, had to submit back in October?
There was no expectation to set this out. It's a new request that this happens now. And the CDC is currently, in fact, working with states to see how that can happen. But, so the main point really is that the equity story doesn't end with establishing priority groups. And in many ways, I think it has been understood in the media and otherwise in that way. But it only starts here, right? Because disadvantage and disadvantage indices matter when we allocate vaccines in the general population, and just as much in all prior phases that we're still in now. So in this sense, it's really good news that the federal government recognizes this and asks jurisdictions to describe what they do using the SVI or another index, because this can really provide a helpful equity compass in these choppy waters that we're still navigating. It's not smooth sailing by any stretch of the imagination, but I think what we have is a guiding North Star with equity and a measure that can help us get there by making sure that within each of these groups that we're moving through, we can make sure that worse off people aren't left behind.
And just to be clear, what we know so far about vaccine allocation is they are being left behind. Whites are being vaccinated at a higher rate than blacks, for instance, despite the fact that blacks have been overly burdened by the pandemic, other minority groups as well, and that wealthier areas are getting more vaccine than areas harder hit by the virus. So, it's on the ground. This is what's happening, and we need to fix it. We need to change that.
That's where we have this really good direction coming from the federal government that understands this. And likewise, that's what we try to show in our review, that states are realizing this too and are very actively trying to redress this in a way that is legally safe, because of course that gets into very treacherous waters. And that's again another real advantage of a disadvantage index, to use it to address those issues.
And we'll throw a link to our review in our write-up of this. Harold, just another quick question. We know that the federal government allocates vaccine to jurisdictions. We're also starting to hear about like mass vaccination clinics, mobile clinics. Pharmacies are going to get direct allocation. FQHCs, federally qualified health centers, are going to get direct allocation. Does that complicate the equity picture? Does it improve it? How's that going to work?
I think it complicates it in terms of understanding where do vaccines go, and planners at the state level that might not be fully looped into how many vaccines go to pharmacies, how they should factor that in their allocations. But what is the really promising sign there is that these are all ways in which we can promote equitable allocation, especially, for example, through the recent Federally Qualified Health Center initiatives, right? Because that really goes to areas that are looped into networks that more disadvantaged people have known and are using for some time. And it goes directly towards addressing the kind of inequitable patterns that we've seen so far. So, using a disadvantage index to plan the location for mobile clinics, for example, to work with community partners and devise targeted strategies for communication. Those are all ways in which we can really make this work.
Can I say that I think that allocating directly to FQHCs could help improve equity. Allocating to pharmacies may, in fact, make it worse.
I mean, this is one really important thing. I live in Manhattan, for example, right? In a mile radius, I have America's most expensive apartment, not my direct neighbors, and a housing project like any other one, for better or worse, also not my direct neighbors. But a huge variation in terms of disadvantage and advantage over a small geographic area. At every street corner, we have a pharmacy. So as a planner, what does that mean? Do I just divide my vaccines by the population and then give every pharmacy an equal share? Well, no, it does not. What I should be doing is make allocations to the pharmacies closer to the projects much larger than the ones that are closer to the advantaged populations, so that there's less scarcity in those areas. It importantly also speaks to a difference between the indices that we can use. So the SVI is pitched at a much higher geographic area level, whereas the ADI, the Air Deprivation Index, works on a neighborhood level, so 600 to 3,000 people, and the SVI works at a much larger census tract level. So you can really get a lot of granularity, and that reveals those disparities and respond to them directly by choosing the right index. And that's another really important thing that I think we have the tools for, and we can make work precisely for the reasons that you flagged.
That would make a huge difference in Philadelphia, because we're a big city and we're a dense city, but there are parts of the city that are absolutely pharmacy deserts. And there are parts of the city that have big chain pharmacies that are likely to get allocation, and other parts that have just wonderful local corner pharmacies that, maybe aren't going to be first in line. So Susan, let's turn to you and hear what's going on in Michigan, because I think this is a fascinating sort of case study application of how do you implement these equity goals and equity measures at a state level.
Yeah, I'm not sure I'm going to be able to answer the question of how you do that.
Okay.
I'll give you a little bit of background on Michigan, and that is, just like basically the rest of the U.S., that minority and low-income residents have been harder hit by the virus. Blacks, African Americans, Hispanics, Native Americans. And the state has responded. So Governor Gretchen Whitmer, that woman from Michigan, has, and the Michigan Department of Health and Human Services really recognized racial disparities quite early, and we were one of the first states to start collecting and making available data about racial and ethnic makeup of cases and deaths and testing. They used the Social Vulnerability Index to establish COVID testing sites and flu vaccination sites. And they're building on that with the vaccine allocation as well. But they also engaged faith-based organizations, tribal councils, and some other community organizations to be places where people could get tested and flu shots, and again, are starting to build on that for vaccine distribution and allocation. So the vaccine allocation plan states that we're using the SVI within phases, and their goals, their recent goals, are efficiency, effectiveness, and equity. One of the things the state did is they dropped the age from 75 to 65 quite early. So it was really more in, I don't know, 1B or something, phase 1B. And they did that as a response to disparities, because one of the things we know is that minorities and low income people are less likely to live to 75. Okay, so they wanted to make sure that the age cutoff was not contributing to a problem with equitable distribution. So that's the allocation plan. Then there's the reality.
What's the reality? You sent us an amazing map that we're looking at. How is this actually rolling out?
Yeah. So the map shows, if you can see, the darker areas are those with the greatest social vulnerability.
Yep.
Okay. And the dots, the size of the dots indicates the number of people vaccinated, basically. And some of the little diamond shaped things are planned vaccination sites as opposed to having had vaccinations.
Okay.
The little bluish green dots are actual large vaccination sites, so the sort of mass vax thing. Okay. So, and what you can see from this map is that it's all over the place. I mean, yes, some of the areas with the greatest social vulnerability, and if you find like Isabella County, which is in mid-Michigan, which includes one of our Native American tribes and reservations, there is a big orange dot there, okay? And right over kind of the dark purple area. The vaccination sites are sort of following SVI and sort of not. Now, why is that happening? Well, storage, administration, uncertainty of shipments is huge.
Yeah.
Logistics of distributing the vaccine and being able to do second shots. I mean, you need this. You need sites that can do this, right?
Mm-hmm.
So that's one of the realities. Another reality within phase 1A, remember back then, starting in December, vaccine was largely distributed to health systems. Now that makes sense, right? You want to vaccinate healthcare workers. The question is, did they use SVI? Did they target health organizations that were located in, worse vulnerability areas? I don't know that we know that. And finally, another plan versus reality is that Michigan does not have racial and ethnic data publicly available for vaccinations, at least not yet. They do require, in scare quotes, providers to collect it. And I put that in scare quotes, not because the state isn't trying to do that, but because collecting racial and ethnic data is difficult. And we see this no matter how hard you try, it's just, do you do it because somebody looks at somebody and says, oh, they must be a Black person or a white person or this, or you look at a name and, oh, they're Hispanic, they're Arab American. The complexity of collecting the data is there. So those are some of the sort of plan versus reality challenges in terms of what is happening in Michigan.
SVI actually help with that, in that we can, at least if we know the zip code that the person lives in, we can see how vaccinations are accumulating in either census tracts or zip codes by SVI. Okay.
Yes, and actually, I think it's important to be able to look at the data. This is the research part, Allison. To be able to look at the data about SVI, which has been done in Michigan and nationally by one of my colleagues here at Michigan, or several of my colleagues here at Michigan, actually, to see, are we in fact vaccinating more in more vulnerable areas or not?
Okay.
Okay, so that's something we need to be able to track. And if you can have good racial and ethnic data, which I still think we should try to get, obviously, then I think it's important to do that.
And this is also, it's one of those cases where the perfect shouldn't be the enemy of the good, right? So
Yes.
as you both know, race is in fact one of the 15 variables, race and ethnicity of the SVI.
Right.
So at the geographic level, we do have some data from, census data, basically. However, as you rightly said, right, at the individual level, it gets really tricky to collect it. Having said that, colleagues and I did another study where we compared using the Air Deprivation Index that does not include race to the SVI. There certainly is a lot of correlation precisely because disadvantage is playing out in such ways in this country that more people who are minorities are among disadvantaged groups. So I think we do have, in the aggregate sense at least, a good handle on making sure that this disparate impact that we've seen across racial and ethnic groups is addressed through overall measures of disadvantage. But you're absolutely right. Getting this precise picture is very, very hard.
It's complicated. And, this is a hopefully once in a lifetime, once in a century pandemic. And, we're learning as we go in a lot of ways. We didn't have the SVI in 1918.
And Susan, another question. So there have been some rumblings recently about using SVI in the first place in Michigan, right? So some people said, well, this can't be based on social values, but it has to be based on scientific values. And as Allison will share with us in a moment, those two things are, for better or worse, very directly related. And that's a false dichotomy to suggest that. But can you just unfold that a little more for us? What's going on there?
Yeah, so this is, again, part of the plan versus reality, and that's political factors, right? So in Michigan, there have been a fair amount of protests against and refusal to adhere to some of the public health restrictions and recommendations. On the other hand, Whitmer, that woman from Michigan, enjoys a lot of support from the population. Like 2/3 of Michiganders, when polled, have supported her handling of the pandemic. And Dr. Joneigh Khaldun, Dr. J, a wonderful woman, has also had, I think, a lot of credibility, not just with Michigan, but nationally. She's now on a national task force for COVID and equity. And they've set a goal of complete equity, so zero disparities. Now, to me, that means that doesn't mean that the people in this particular county are being unfairly treated. It means that, in fact, they're being fairly treated if we're going to have perfect equity. I'm not sure we can have perfect equity, okay, but if the goal is to have zero disparities, then how does that hurt people? I'm not sure you can argue that.
That's such a great example of what something like a focus on equity or science-driven equity measures or goals, how it upsets people who feel like they're going to be unfairly treated. And maybe that's a good segue to our last segment on where does the research come in on this? How do we do, who's doing research on equity and vaccine rollout, and how should we be doing it and what should we be studying? So I brought a paper. We want to sort of highlight recent research that is central to this topic. It's a paper from JAMA Network Open. And again, we'll drop the link in our write-up from a team also at Michigan, Susan's colleagues, Manita Karmakar and
Go Blue.
Go Blue. And it's on the association of social and demographic factors with COVID-19 incidence and death rates in the US. So it's not actually a paper on vaccines, but it came out in January using the same data we've all been looking at from the Johns Hopkins repository and the Social Vulnerability Index to see, is there a relationship between SVI and how hard a county or a local area was hit by both incidence and mortality for COVID between March and July of last last year. And the scientific findings are quite robust. So they translated it very nicely into some numbers that we can compare that I'll read out so we can get an idea of how much this SVI matters. So counties with greater SVI scores, which reflects greater sociodemographic disadvantage, had higher COVID-19 incidence and mortality rates. And their example is a mid-sized metropolitan county that has an SVI score at the percentile mean, which was 0.5 in this scale, was estimated to have 604 cases and 15 deaths per 100,000 population, while the same county, a comparable county with the same characteristics, but an SVI score one tick up, so 0.6, had 691 cases, so 691 versus 604, and 18 deaths versus 15 per 100,000 population. So 87 excess deaths and 18 excess cases, 3 excess deaths per 100,000. There's also a really nice figure, which maybe we'll drop in on top so you can see how the trajectory of the pandemic also moved much more quickly. So cases and deaths rising much more steeply as the SVI index increases across all counties in the US. So I think a really nice application, scientific application, it's in a JAMA journal of the SVI that I think sets us up well for comparable analyses for vaccination, right? There's the sort of scientific credibility that we can pull these data sets into the same place, have a rigorous outcome measure like percent of vaccine coverage or an equity measure, and see how that relates to SVI.
So I want to bring up a couple points. Obviously, I know the paper and I know the people, but they did it at the county level, and counties are pretty heterogeneous, right?
Yeah.
So within a county, you can have, very vulnerable areas and not so vulnerable areas. So I think this is something that needs to be, I think we need to dig deeper into that. I also wonder so another thing is the timing of that publication and the data was, was it, I think May, something like that?
They get through July.
Through July,
2020,
okay.
yeah.
And the surges in the later parts of 2020 were much different and in much different places. In Michigan, for instance, we saw the rural areas really being hard hit later on in the pandemic, whereas Detroit and Grand Rapids, urban areas, were hard hit early. Okay. So that's, I think, another issue that we need to what happened later? What happened later in the pandemic? And did we see similar relationships? I suspect we probably did, or will, or do. But my next question is a National Academies group, and they mentioned the possibility of using not just SVI, which is what we've been concentrating on today, but possibly using, I think, something they called the COVID Vulnerability Index. And there is a professor in Chicago who has looked at vaccination by area and COVID mortality. Williams is his last name, and found that where the vaccinations happened and where the mortality is very different. I wonder if using something like that could be politically more acceptable because it's specifically based on COVID vulnerability. So I'm just going to open that up and see what you guys think.
I do think it does merit attention to ask what index are we using. We talked earlier about the geographic resolution. To your very first point, that's true where the ADI provides a much more nuanced picture. But I think we also have to accept, the realpolitik of the situation that we're in. Your main point is absolutely essential, which is how do we frame this discussion, right? Is this about social justice or about risk? The truth is, it is about both. But I think that the key message here is really not to quibble over, at this point, which is the best index to use, but to just say disadvantage matters. And we have hard data to show you that it does matter. So
Let me challenge you a little bit on that, actually, if you don't mind, because
of course.
One of the things you said was, oh, please don't change anything now because that'll just mess everything up. Okay. I mean, I'm paraphrasing you. Okay. And that's kind of the efficiency argument. And I agree that's a problem. But I also would say that this is not going away.
Right.
This is going to be with us for quite a while. And that even once the supply opens up, that where we vaccinate and how we vaccinate and how we get vaccine into arms, okay, matters, and targeting on the basis of different measures of disadvantage. We can change things potentially, not immediately and not in a way that disrupts some of the efficiency problems. I totally agree. Let's just make sure equity is, front and center, okay? And that disadvantage matters for doing that. But I also think we can learn as we go.
I think that's a great place for us to wrap up this first covered dialogue. So we're focused on COVID vaccine equity research here. We had our guest, Dr. Susan Gold from the University of Michigan. I'm Allison Buttenheim here with Harold Schmidt at the Leonard Davis Institute at the University of Pennsylvania. Thanks for tuning in, and please come back next time.